So stop and say, that's pretty cool if you're a snowboarder. That's pretty cool if you're a kayaker. But I did that for a reason because while I think that's a really cool video, and I'm always impressed with somebody who finds a way to talk intuitively to their customer base, right? They showed a grandma operating it. You're like, really? Oh, it had the words in there. I mean, I think we need to learn from things like that because it teaches us how to talk to a constituency silently. There wasn't a single person talking, and yet you walk away knowing almost every feature, every functionality, right? So there's a lesson in that video, just watching it and the music and the other stuff to inspire you to want to do something with that product, and that's what they do for a living. But I also want to talk about the fact that drones, UAVs are here to stay, and in public safety, especially in emergency management, I think we need to really consider what their impact can be to the positive. Yes, they're flying into planes or trying to. I get that. Everything has a negative. But can you imagine having a pretty good sized 6-blade drone restocking an MMU forward from a central base back at a DDC staging area or an RSA, flying forward? It may take them 5 flights or 10 flights because they only carry 20 pounds at a time. If you get 10 flights over 20 minutes from a couple of drones, are you okay to get your IV supplies and other things? I am. We have seen where drones can help with imaging. They can help with resupply and other things. And I really think in the next 2 years, we're going to see an explosion of that technology, and we're going to have to embrace it. And I want to be on the cutting edge. So we'll get started. It's going to be a good day. We'll call to order the Disaster and Emergency Preparedness Committee. Roll call. I am here clearly. Michael Beimer. Here. Tim Berry. Here. Brad Gowdy. Here. Wanda Helgeson. Here. Dr. Kidd. Here. Chief Kidd. Here. Robbie Curtin. Here. Sari McCoy.
Here.
Shalom Montgomery.
Here.
Dr. Morber.
Here.
Sharon Knowles.
Here.
Rennie Perez.
Here.
Ricky Reeves. Bueller, Nick Sloan, Edwin Smith, Kenneth Webb,
Here.
Michael Wilson. All right. Oh, excellent. Thank you, guys. First up, actually, it'd be pretty easy. We're going to discuss TDMS today, the EMTF stuff. We have Bruce Clements from the Preparedness Director for DSHS joining us. So we're going to talk about some of the Ebola preps. That's going to be good. So that's enough for the first 45, 50 minutes here. So I'll turn it over, Dr. Kidd, to TDMS stuff. We'll go first.
Well, I won't belabor a lot of the Ebola stuff. We actually did not have a meeting in June because of our friend Tropical Storm Bill. But in the May and July and going into August meetings are having a lot of discussions with DSHS about Ebola funding and the upcoming regional meetings. So I'm assuming we're going to talk about. Oh, sorry.
Thanks. Y'all keep us honest on that. I can hear her perfectly.
Can y'all hear me?
So.
Okay. We have been having, we did not meet in June because of Tropical Storm Bill, but the other meetings and then upcoming meeting tomorrow have been having discussions with DSHS and Bruce and his folks about the Ebola funding and the upcoming regional Ebola and high consequence infectious disease meetings. And Bruce, I'm assuming we're going to talk about that today. We're going to be meeting with Lisa Dixon to talk about the FirstNet stuff. If y'all remember, we met with her, was it last quarter, to talk about that. The TDMS overview document revision should be completed and finalized. We've been talking on resource typing and have finalized some of the resource typing documents for several of the public health teams, including CASPER, RAT, CAT, AST, and EMTF teams, currently working on rotor wing, fixed wing, the rabbit, and the bat teams, which we're also discussing those teams.
Whoa, there's a new one.
Behavioral health assessment team and...
What's a rabbit?
Now you're...
No, I know what a rabbit is.
It's another behavioral health team. We're not sure yet. That's what we're having discussions about.
Okay, we're coming to a close. It's like when.
Thank you.
It's like when it's like when Mac changes from Yosemite to other names. I mean, at some point, we need to find another. We went through all the animals. We're going to be at all the rodents. We're going to be everywhere.
That's what we're having discussions about.
Okay.
Teamwork team, Texas Mass Fatality Operational Response Team. Basically, we're kind of at a crossroads with the teamwork team. Everybody's on board, including all the chief medical examiners, DSHS, TDMS. Everybody's on board with these teams. The question is, how do we move forward with them? And we've had discussions about finding a university home for these. Not sure how long that's going to take, but in the meantime, we're talking about, and talked last time, about developing teamwork MOUs similar to the ambulance strike team MOUs that we did several years ago when Maxie was still at DSHS, and have some of the same discussions and hopefully get some of our mass fatality colleagues around the state on board with at least signing an MOU, so if we have a disaster, there will be a mechanism for them to deploy. And so that was the last discussions we had on that. Daniel.
Emily, can I ask a question about that? So, Bruce, this is actually to Smock, Bruce, Jeff. I don't know if Jeff's here yet. So, if we had, absent those MOUs, if we did have a problem today, I mean this afternoon, we can single resource them with some kind of way to do that if they're willing to do it and do shock contracting things in an emergency. If we have a plane, I mean, it's something bad.
Yes.
Okay.
It's just not organized.
Absent.
We're kind of where we were during Katrina and Rita with ambulances right now.
Got it.
Basically, and so the idea is to develop some MOUs in a more organized way to have mass fatality response if necessary.
Cool.
DGRIM and Danielle Huss are working on hospital mass fatality survey and some guidance for hospitals on mass fatality planning. And tomorrow we're going to be having a bloodborne pathogen discussion with Dr. Graves, Dr. McGraw, and the DSHS folks about how do we protect our responders if there is a bloodborne pathogen exposure downrange. And actually the drones might be an option. Future discussions are alternate care sites and how we incorporate some planning for those. And I'll leave it at that, and I guess bring Bruce up. Ready?
Yeah, or you want to swap to Joe? Actually, you want to put Joe past Bruce. So let's go to the Ebola stuff that kind of ties in with TDMS, and then we'll go to the next part of that as well.
Good morning,
Joe,
everyone.
where you at?
Oh, one other thing about TDMS. The recommendation was brought up at our last TDMS meeting to have TDMS monthly updates to send out to everybody, and be working with the group tomorrow to finalize a format for that. So I think that's going to start happening just so everybody's kind of aware of the discussions we're having.
So Bruce, I want to do something real quick.
Yes.
Everybody in the room, pay attention. You're going to be voting for about 20 seconds. It won't take long. You have to raise your hands for a couple times. If you are from a urban area and you know what those mean, raise your hand. Urban areas, okay? Down. Rural areas, raise your hand if you're from basically not one of those other terrible places. I see you. All right, good. If you are from a hospital primarily, your job is hospital preparedness, hospital emergency, you're an ER nurse, whatever, raise your hand. Okay, put it down. All my EMS dudes, where are you at? Raise your hand if you're a pre-hospital, air medical, whatever. Okay, so I say that because I think this is one of those groups, Bruce, that is underutilized sometimes when we talk about the infectious disease processes. Mm-hmm. You know, that does always involve the infectious disease practitioners, the preventionists. There's lots of things inside the building, and the public health epidemiology, the shoe leather epi stuff that has to be done. But the reality is the people in this room, I know, speak to me a lot, and I know you and I have talked personally about it. You know, these are the ones literally on the front lines. They're on a front porch with the people, and so the plans that we put in place to care for those patients, the things you guys, the important work you're doing, these people in the room represent the folks that appreciate that work, and it means a lot, literally life and death to them. So, go ahead.
All right, thank you. Good morning, members of the committee. Thank you for the invitation to speak, and I'd like to try to accomplish three quick things. One is I'd like to give you kind of a threat update as far as where Ebola stands right now, and how many people we're tracking in the state, what the outbreak in Africa looks like. I'm going to touch on that briefly, talk about a few of the lessons learned, and in the context of the lessons learned, I'd like to talk about the infectious disease response unit concept, And then I'd also like to cap it off. I've invited Jody here from Disease Control and Prevention, and we have a House bill and a Senate bill that affect the members, the folks in this room and members of the committee. I'd like her to come up and give you a quick summary of those bills and the status of implementation. So first of all, a lot of folks don't really understand just how huge the Ebola outbreak has been in Africa. Relative to other kinds of outbreaks, it's relatively small. And if we talk about influenza outbreaks, this would be a drop in the bucket in terms of numbers. But if you think back, the organism and the disease was first identified and diagnosed in 1976, and since then we've had 24 outbreaks in the history of the disease until last year. 24 outbreaks, 2,400 outbreaks, or 2,400 cases, so about 100 cases in each of those on average, 100 cases in each of those 24 outbreaks on average. 1,500 deaths, 66% case fatality ratio, and the largest outbreak until last year was in Uganda. There were 425 cases, 224 deaths. In the past year, this is more than 10 times larger than everything else in history combined. We've got 27,000, almost 28,000 cases. We've got over 11,000 deaths. But fortunately, the case fatality ratio has dropped down to about 40%, which is really just representative of just better health care being delivered to Africa at this point. And so you can see down in the bottom right, where it's zoomed in on the three countries where we still have cases, and that's Guinea, Sierra Leone, and Liberia. Excuse me. And the places where you see orange are where the final cases are. And it looks like, it used to be all of those three countries were just bright orange. So you can see they've kind of got it on the run. There's pockets of the disease that they're still dealing with, and it looks like things are going well. In fact, here's what it looks like over the past year. So what you see there are the cases. The green line is Sierra Leone, red is Liberia, and the blue line is Guinea. So you can see early on we had a huge number of cases in Sierra Leone. Those are down to, right now we've had single digits for 3 consecutive weeks, and Sierra Leone has no new confirmed cases since the week ending August 15th. So Sierra Leone, which was those tall green lines early in the year, is now down to where there's just a handful left. Actually nothing left in Liberia at the moment, and then a few cases in Guinea and Liberia. So we're down to single digits of occurrences, and it looks like things are winding down. And what does that mean to Texas? Well, first of all, we've had 3 of the 4 fatalities. So there have been 4 diagnoses of Ebola in North America, 3 of them here in Texas, and the 4th was a physician who recovered in New York City. Here's what we've got going on right now. As you all may know, we monitor folks. So when individuals who've worked in Africa on the front lines, or people who just are visiting relatives coming from Africa, when they come here to the U.S., they're required to come into one of 5 major airports. So if you're coming from one of those 3 countries, you're required to travel into one of those 5 airports. You're screened by the CDC. CDC sends that information to our Disease Control and Prevention section. So we know when people are coming in. And either local health officials or some of our regional staff will contact those individuals when they get to Texas and serve them with essentially a control order saying, here are your instructions. We need you for the next, and it's 21 days from the time they've left Africa. For the next 3 weeks, you need to take your temperature every day. For some of those folks, we have them actually get online and look into Skype or FaceTime and take their temperature and make sure that they look good, that their temperature's right. And so that extensive monitoring has been going on for quite a while. To date, we've had over 1,100 cases that we've tracked. Right now, we've got 34 low-risk individuals in the state of Texas and 1 with some risk. Some risk usually means that they had some sort of contact, like they were a healthcare provider in Africa, and now they're back. So we've gone through a lot of cases, and keep in mind that out of almost 1,200 cases, that we haven't had any new cases. So the risk from here forward is very low. But we do have, again, some legislation that we'd like to talk about concerning how we can share more detailed information on who's being tracked, and I'll get back to that at the end of this presentation. And Eric asked, there's just so much here. Eric asked me to kind of do a quick recap of some of the response issues. This is just the short list of the challenges that we face. This was very atypical. We've dealt with big pandemics. We can do antiviral distribution and optimization. We can do vaccine distribution and optimization, mass vaccination clinics, mass prophylaxis. We're good at that stuff. This was really strange. One case created all kinds of challenges that we really aren't accustomed to in public health. First of all, one of the first things that happened that was really problematic was PPE guidance was off. And if you look back in the Lancet, it's a very respected journal, a lot of you know this, in UK. It's kind of like the New England Journal of Medicine in UK. There was a debate going on in the literature last summer, and someone had published an op-ed saying, you know, we really need to think about conserving PPE. I think it's overkill. If you look at what they're doing in Africa and you don't see any exposed skin, that's overkill. This is a droplet spread disease, and we need to have droplet precautions like we do with any other droplet spread disease. So those were the recommendations that came out. And by the way, somebody countered that in the Lancet and said, no, this is really different. You can't say that this is, you know, MRSA in a hospital setting. This is a whole lot different. Even though it might be spread the same way, this is a whole different ballgame, and we should be as conservative as we can be with this. So that debate was raging. We had, when this case was discovered, recommendations were coming from the healthcare quality folks at CDC. These are the same folks who do, you know, the infection control guidelines, hospital or healthcare acquired infections, things like that. Those folks came out with the recommendations of what PPE to use, and it was based on droplet spread infection control precautions. So it wasn't the global disease folks. It wasn't the high path, high consequence disease folks at CDC that made these PPE recommendations. It was the hospital folks. And then what we found was, and this is just a picture in the bottom left or bottom right from USA Today, showing the before and after. So when Mr. Duncan got to Presbyterian Hospital, what you see on the bottom left is the PPE that the nurses were wearing at the time. And there's exposed skin. And for droplet precautions, that's appropriate. But then we had 2 nurses get infected. Shortly thereafter, the PPE recommendations were changed to what you see there on the right, which is much more reflective of what you see them using in Africa. So we had issues with PPE recommendations, and those issues aren't over yet. OSHA has their recommendations, NIOSH has theirs, CDC has theirs, and we were in DC, David Gruber and I were in DC recently, met with some senior leadership in some of the federal agencies, and we had a discussion about some of the issues that still need to be addressed, and this is one of them, that we really need one voice, one place, you know, one group that we can go to that gives the PPE recommendations, not OSHA with theirs, NIOSH with theirs, CDC with theirs, and by the way, within CDC, a couple of different ones depending on which center or division you're working with. So that was one of the big problems. Ground transportation, obviously, that was a problem. We really weren't ready for that. He wasn't identified as anyone who was high risk. Therefore, the folks who transported him got administrative leave. Ambulance was taken out of service, and we had to do trace back on who all had ridden in that ambulance, and also put them on control orders and monitor them for 21 days. We were lacking a lot of protocols, basic protocols, 911 protocols, EMS protocols. They didn't exist when we had the event, and so, but they do now. Waste management, both the hospital waste and as well as the community waste, that being the remediation of the apartments, that was a brand new game for public health. Now TCEQ was involved, but it became a big challenge for public health as well. And of course, emergency management, when we got that system up and going, DDC was activated, a lot of these things became a lot easier because we were using the incident command structure. Contact tracing was problematic, especially given the second nurse that got ill and the fact that she hopped on a plane to Cleveland to plan her wedding. She had a 99-point-something fever, called CDC, and they said, well, you aren't at 100.4 yet, so you're okay. So she got on the plane and flew home, and we had over 100 people we had to trace from that. And by the way, that also resulted in a lot of really poor decision-making at the local level. Up in Bell County, they shut down part of a school district and brought in hazmat teams to clean the schools because there were some children who were on that plane with the nurse. So you know, a lot of education we need to do there. The pet issue, we had never had issues with pets. You know, the dog that belonged to one of the nurses, his name was Bentley, which is appropriate because we probably spent as much as you would on a Bentley to take care of the dog. But new protocols have been developed for that. So there wasn't any protocols, there are now. The American Veterinary Association has multiple committees developing things. Control orders, we had control orders on property, on cars, on people, on dogs. Learned a lot from that. Behavioral health, we had behavioral health issues. We need to include them earlier and get them more engaged earlier on in an incident because obviously the mental health piece of this is huge. And fatality management, we were really fortunate to have Dave Patterson here, the director of the Texas Funeral Directors Association. He came up on his own with some of his material. We couldn't find anyone else. I guess calls were made to some of the local places around Dallas that did cremations. No one would take him. Dave Patterson said, I will. He came up, and the healthcare workers all stepped back in the hall and said, "It's all you." And he said, "No, I need help." So one physician volunteered, and the volunteer turned around to a young resident and said, "It's you and me." And so they practiced.
We call that voluntold.
Voluntold, there you go. And so they practiced out in the hallway. They ran through it 3 times, where they practiced, laying out the body bags, and then they used the BioSeal system, which sealed. He was in 2 body bags and then sealed in BioSeal, which is kind of a metallic cover that you crimp all the way around and it seals it. So they ran through it 3 times. They went into the room and they bagged him, got him out, and actually drove. The media was up, kind of overlooking the back parking lot. They drove underneath the media in a hearse and discreetly pulled out with DPS pulling out behind them in an SUV. And we didn't have the OJ scene of the helicopters following the hearse down the highway. So that worked out well. So we learned a lot from that. And by the way, we've gotten funding now. 2 sets of funding. The FEP funding is really on the public health side to support additional planning, operational readiness, to help build our response infrastructure and enhance collaboration, coordination, et cetera. And then we have the hospital preparedness program. It's in 2 parts. One part is for everyone across the state to use, and it's to contribute toward CONOPS and toward planning on a local and regional level, regional with a small r within the state. But then we have Part B, where we have funding specifically for an Ebola treatment center. In this case, UTMB is the only one in Region 6, Federal Region 6. So Louisiana, Oklahoma, Arkansas, New Mexico, Texas. The one federally designated center in our federal region is UTMB. And so they're getting additional funds to serve that role.
How many beds do they have?
2, but they can surge to 3. Yes.
Okay, Mr. Glass is half full.
So more work to come on that. And we're also running into issues with this, the tiered system. This is what the feds came up with. We didn't dream this up. So they think that every hospital, the feds gave us guidance, every hospital should fall into one of 3 categories: frontline, assessment, or treatment centers. And there's specific criteria for each of those. So all hospitals at a minimum are frontline, and you can't really read all that, but we can share the slides with everyone if you'd like to. That the frontline hospitals have this basic, they have to be able to identify a case, to isolate the case, and to communicate, with others to get that case moved to an assessment facility. So it's really just you need to be able to identify, isolate, and then coordinate the movement. Assessment hospitals, you have to be able to hold them, in this case for, they're saying PPE sufficient for 4 to 5 days, and that they should be able to hold them for about 96 hours. And then from there, they'll go to the Ebola treatment centers, which is where they have the rest of the care, which typically lasts a week to 10 days, and they either recover or expire. So it's usually a week to 10 days that you'll have an Ebola patient. So that's what they've given us. What we found, though, is we did a survey a while back of all the hospitals in the state, and we had a number of hospitals say, yes, we're ready to be Ebola treatment centers, and others said, we can be assessment centers. And so we started calling and saying, well, then we'd like to send a team out. CDC has given us the guidance. We'd like to send a team out and do a quick assessment, make sure that you all meet the criteria. And they started dropping like flies. They don't want anyone coming in to assess their preparedness level, and they don't want to be put on a list as being identified with any of these. Not all of them. We do have some. How many assessment hospitals do we have right now, Carrie? We have 33 out of about 600 hospitals in the state that have agreed to be assessment hospitals. And we've got really 2 Ebola treatment centers, UTMB, and then Children's has an 8-bed unit, Texas Children's in Houston. So that's for PEDs. So that's where we're at on that. But now I'd like to, and do you have any questions on that?
I do.
Go.
Ooh.
Yes.
So I understand that in your role in the preparedness division, right, in your role, this is a supportive partnering with healthcare systems. There's another part of your organization that has significant regulatory function to healthcare systems. It's usually not a good day when DSHS arrives and says, we'd like to see the CEO, we're here to help. Like, it's not usually a good day. So I think that one of the swing and a miss, I think these guidelines are great. And I think it would, I'm going to try to provide some perspective to you guys. It's as if CDC came up with a new idea. They want 10 states out of 50 to do something special for their lab testing, but you didn't go to the meeting where they created the thing, the rule sets. You don't know who's going to govern how those 10 state labs are going to be used, right? And they said, oh, you're going to sign up? You said, well, we're interested. We'd like to learn more. He said, we'll send a team down. We're coming down to evaluate and provide. I mean, I know it was done a little bit nicer, but you have to hear when a trooper says, can I see your driver's license, please? It's very nice, but not good, right? I have found in general it's not necessarily the best moment. So my sense is, and if you're willing, I would like to find if there are opportunities for us to increase that number from 33. I think there are. I know of 2 in our town right now, and frankly, I'm not sure if they qualified or agreed to the thing or not. But I know that's where we're going to use for our assessment centers, and that's where ground truth is. My bet is you have way more than 33. Whether they're going to be on your list or not, that's where they're going to end up. Is in that middle tier. There's going to be patients if we have another outbreak. It doesn't matter if they're on the list because we're going to bring them to those 2 facilities because our regional plan, in concert with our local and regional health teams, that's what's going to happen. We're not going to take them to another town. And so if you guys are willing, RACs in the room, HPP folks in the room, could we help them? I think if we could bring them together like in a summit with their CMO and those kind of people, and maybe in those smaller groups, if they felt like they had a little more. I've heard from one of them that said we just didn't know what the survey was going to be. We're not going to invite a survey process in willing. I mean, that's not a good thing. So I think if they understood what the purpose was, got to meet you, understand who the team is and what the criteria was, everybody wants to know they're going to win and be successful. Mm-hmm. No one wants to be embarrassed. And so if we could help with that, we'd be glad to. Is that something that would be helpful?
Sure. And actually, we can take that back. We've actually got 2 different grants that are working in that direction. There's our HPP grant, Part A and Part B for the Ebola supplemental. There's also an Epi lab capacity, ELC grant, and so there's overlap. The feds kind of gave them responsibility for it in their program and actually asked them to go out and visit. Then they also put it in our grant as well. So we're still kind of marrying up our program and our efforts at the state level to develop the strategy. Did you want to say anything about that, Carrie, or did I cover that? Come on up. Oh, by the way, this is Carrie Kane. She's the team lead for our HPP program at DSHS.
So basically, like I said, as Bruce said, we're working with our EPI partners on the ELC grant. And it was actually their grant that had the charge to go out and do these visits. And the language in our grant says that we should cooperate with them and help them and support them in that, which of course we're doing. So we definitely would welcome additional support, especially I'm less concerned about the overall numbers of the number of assessment hospitals than I am about making sure that we have adequate geographic coverage across the state. Because we do have some holes when we look at where those assessment hospitals are, and there are definitely some places in the state where we need to identify some. And in those cases, we have already been talking to our HPP contractors as well as our health service region folks, and they've begun those conversations directly with those hospitals to try to fill those holes.
Do we have that list?
I have it.
Is it secret? I mean, is it a secret list?
No, it's not a secret.
Do we have it, Mark?
Can we share that?
We've shared it at HPP meetings before, the map, but we have promised those hospitals when we've talked to them that we would not be
broadcasting it on the internet.
Right.
Right. Streaming it on live. Okay.
You may want to just carry on just the difference in some of the hospitals that, and you worded it differently yesterday, but said they would, but may not want their name on the list. Is that the best way to put it?
Is that due to the business impact when the population finds out that you have an Ebola patient at that hospital, that nobody else will go to that hospital?
Well, that's part of it. The other part of it too is if you go on the list and say we can take an Ebola patient, or we'll be the assessment facility for this large regional area. What you've done then is you put yourself on the list to receive a patient from outside your normal catchment area. And so a lot of folks that, like San Antonio, I think some of those conversations where we're in the local plan, we'll work with this. We'll do we will be it for here, but we don't want Texas to send someone from Lubbock to San Antonio for treatment. I think that's kind of part of it as well. They just don't want to be on a list where the state or the feds are going to send them anyone.
And frankly, I don't think we should be sending anybody to go from a front line to an assessment center from Lubbock to San Antonio.
Right.
I mean, to be
fair. That was kind of an exaggerated example.
No, I know. I think that's the challenge, though, right? We have to embrace this like we would trauma. I mean, we need to have level 3 trauma centers in San Angelo. We need to have level 3 trauma centers in Victoria. We need to have level 3 trauma centers in, running out of sort of middle ground. I mean, we need to have those things. These transports don't need to be hundreds and hundreds of miles. It's already hundreds of miles just to the level 3s, right? My Frontier colleagues. So the quicker we can find a way to get adequate geographic coverage, and we're anxious to help. I think it's almost always in the presentation, and you've heard my conversation about having a flat tire on I-35 and looking up and seeing an Austin fire engine pull up, and it blocks behind you 3 or 4 lanes, and then gets out to come help you. There was no one really got that. Thank you. So they walk up. The guys are in the bunker gear. They're coming to help you change your flat tire. Right? You're breathing a sigh of relief. Same flat tire, same location. You look up and DPS trooper pulls up, cool sunglasses, gets out, got the things, walking up there. He's probably there to help you with your flat tire, but your first thought was to look at your inspection sticker on your car.
Not anymore because we don't have this.
I do. No kidding. Registration, you know what I meant. See what I'm saying?
Right.
And it's all in presentation, and I think that's where the HPP, the RACs can help you, because they're the firemen, not the police, right? I mean, I know you guys aren't the policeman side of your department, but the initials enough are scary, can be disconcerting.
Eric, I think you're correct. I think if we had approached this going through the coalitions with the people that they know, knowing that the same thing was going to happen, we were still going to provide assessments to those facilities. And, oh, you guys, this is such a wonderful thing. There's this whole team of people at DSHS that are subject matter experts that are going to come and help the coalition do this. So what's happened now is exactly what Eric said. DSHS inviting them in to survey my hospital, I'm thinking not so much. And so we have large areas that have only frontline facilities. And as I said in our meeting yesterday, it really doesn't matter. If you're the only hospital in a 200-mile radius, congratulations, you're the assessment hospital.
Right.
Regardless if you want or not. And because of that setting, those facilities are probably not going to get the assessment. So we're not going to know that all of those facilities are able to do everything they need to do. So I think it absolutely is presentation.
Okay, sorry.
And one other quick thing. Speaking of, I did want to throw this out as well, because I'm still learning about the air transport side of this. They have asked us, the feds, when we do these federal region plans, the 10 plans, they've asked us to incorporate several assumptions in those plans. And one of them is that anytime we have a patient more than 200 miles away from the Ebola treatment center, that they will use the Phoenix aircraft that they use to transport the nurses. There are 2 of those, isolation aircraft, and they're one-stop shopping. You get the patient to them, they will package them and take them. They've taken people off the back of trucks in Africa and flown them to Atlanta. So one-stop shop, they'll package the person and take them. They have full
They come
full
to
staff.
the hospital? Or do you have to
no,
meet
we have
them?
to get them to the airport.
Right.
But from the time we get to the airport, they've got it.
Okay.
But if it's more than 200 miles, then we're supposed to notify HHS, who reaches the contract is still with the State Department. HHS contacts the State Department, and the State Department will permit one of the Phoenix aircraft to move a patient. So if it's more than 200 miles, that's the assumption, is they'll be flown.
I think in Texas, that will be the easy. I know that's going to be difficult and complex, but oddly, it's the piece in front of it, from the front line to the assessment center with all the tests before HHS starts cutting private planes loose on big contracts. We're going to know we have an Ebola patient to go to a treatment center, right? We're going to know.
Right. Yeah, they won't
Right.
fly them unless they're
It's-
confirmed.
It's all the logistics. In my world, I think that most things that are missed by clinicians are the logistics associated with this wraparound services. It's like, well, we'll just get them over there. So we're going to magic them over there. That's the heavy lift in trauma. It's the heavy lift in STEMI. It's the heavy lift is a bunch of systems working together simultaneously. It's not the protocol if we're going to give full dose lytics. That was the easiest part of the conversation, right? It's all of the other parts that are tough, and it's complex. And frontline to assessment to the airport, and then we're kind of done in Oswego, someone's going to take care of it. We need to work on those first 2 blocks and the inner pieces, the interrelated pieces of those, I think is where we all have the most opportunity, and I think where we're weakest.
Well,
And that's-
from hospitals, I think.
Get the mic.
From the hospitals, though, the one thing they're going to want to do if it's a suspect is, what test do you want and what phone number do I need to call to get rid of this patient?
Right. Yeah. Yeah, I'm sorry, your local health department. If you don't have a local health department, it'll be the health service region medical authority. But yeah, they're the ones who, and it won't be a big surprise. We're going to know, I mean, the way that the system is set up right now, it's highly unlikely that we're going to have anyone just show up that we didn't know was here that had an exposure. So as it currently stands, there's, I think, pretty solid planning in place where when they meet the person at the airport, they ask them, where are you from? And they make recommendations on where they should go.
So Bruce, I agree with you. I would completely agree with you because, and you and I had the, I know you're a big supporter. I mean, I'm not arguing with this, but I think there's a tendency to confuse. This is globally, not at the Department of State Health Services, not in San Antonio, not in Texas. This is a national. I noticed this trend. There's a tendency to confuse good tactics with good luck. And the reality is, there was a decrease in stress and anxiety once we figured out how to get the international airports to ask the right questions. Mm-hmm. But if you bring yourself back to the day where we didn't know who was coming in and there were people on boats and we didn't know, it's much easier in the clear light of day to go, we need to provide some education to those people in Bell County because we all know you don't have to if they were on the plane. No one knew that when people were starting to pop up after getting sick on an airplane. Certainly CDC didn't know. Everybody was nervous about this. There was not a lot of information saying, don't worry about that. I mean, that's, and I'm not sure the general public necessarily believed that. my point to that is, I don't want us to build plans for detection and for response based on we will know when the Ebola patients are in the country. Because frankly, it's not going to be Ebola the next time, right? So, or it's going to be something that's naturally occurring. So we have a big chimpanzee research thing in San Antonio. It's going to be Ebola Reston, and it's not going to be Zaire or the others, right? So Richard Preston's The Hot Zone book tells you exactly what can happen anytime, and that could be organically done in our country. And we're not going to have flights to be able to pick that up. And I'm not trying to scare people. I'm just saying I think we need to plan as an integrated approach with healthcare and public health, trying to find a way to not game it. We need to not know. We need to not know that they're going to be on a list. We need to not know that the airports are notifying us. They come with a little kit and they have a little card and a number. That's way after the fact. And if this had been something that was highly contagious, highly infectious, I mean, and these are high consequence diseases, but it's harder than we think. This isn't this isn't flu, right? This wouldn't be H5N1. This would have been rapidly terrible in our world if this had not been as difficult as it is to jump, right?
We also need to not assume they're going to come by air.
Right.
Right, and we have had situations like that. And by the way,
that was an editorial, probably not what you were.
But you raise a good point, and here's the whole point of having these Ebola supplemental funds is to get beyond what we've got now, which is we're going to catch them at the airport, we're going to give them a control order, we're going to have them, Skype in every day and take their temperature, we'll get a look at them, make sure. That's what we have going on right now. But with the full understanding that those funds are being given not to support what we're doing now, but to support what we'll do next time when we don't have the luxury of the system we have right now. And so that's why we've expanded to high consequence disease, infectious disease versus the Ebola grant, because Ebola's tired. It's about over, as you saw from this. Right. Every time I say that, people run around and knock on wood, but it really is winding down quickly. And so we need to really refocus on those things that are more likely, and that's what we're doing with those regional meetings, which I'll get back to in a minute. But it's a good segue for a brief conversation that I wanted to have with this group about infectious disease response units. It's filling that gap. Once we identify the hospitals, okay, and we're working on that, the hardest part of this is identifying how we're going to transport patients. Now, we have the Phoenix Air folks who can fly them if it's more than 200 miles. That's great. But we got to get them to the airport. And we got to get them from one hospital to another before we get to that point. So I know that in some areas, I know in Houston, they've got their act together. They know which ambulance companies can do this. They've got the plastic and duct tape ready. They can do it. And I imagine the same is true in San Antonio, where you've got some planning. Looks good. What I'm wondering is, do we have a comfort level statewide that... No. Yeah, thank you. That's where I'm going.
Go ahead.
Because what I'd like to ask the group is, would it be... we have EMTF. And EMTF the concept is outstanding. It's working for us. Those are regional assets that can respond regionally. If we need something, for a big response that's outside of their region, we've got a lot of capacity. If that storm out there in the Atlantic spins up and we need to evacuate hospitals, those 13 ambulance buses are going to be golden. And so are the ambulance strike teams. And so my point is, we've got great systems in place. Should we consider modeling after that? Ambulance strike teams that have some additional capacity to do infectious disease, high path, high consequence infectious disease. So we've got ambulance strike teams, we've got MOAs, we got everything in place, but would it help us to build teams like that we could stand up if we do have a major infectious disease outbreak and need to transport patients? And if the answer is yes, and it sounds like it is, how many of those could we have? And some of this can be limited by funding, but just first of all, what would be the ideal and what would be kind of the minimum? Should we have 2 of these teams, 8 of these teams? What would be ideal in the state?
So let me open it up to the committee, because I'm going to reserve my thoughts. So you guys, what do y'all think about that idea?
I would. It's a great concept, and I would go along with that. We don't need to reinvent the wheel of something that's already working. We just have something that's more specialized. But as far as the quantity or anything, get one complete, and then ask that question: what is going to be the magic number?
Anybody else?
I think we have to look. I think we.
We're trying. I'm getting her.
I don't know what the magic number is, but I think it's more than one, just because of the geography of Texas. And if you're a frontline facility, you're going to want to see people coming quickly.
So let's hold off on. I agree. I think you were saying see what it looks like, build one, as a pilot, and make sure you know. Right, I knew what you meant.
Build one.
So I don't think we need.
At it.
Let's get yes no out of the way before we get to how many, if we think that's a good idea. Anybody from the audience or somebody have a thought, or Dudley?
I think it's huge.
Who are you?
Oh, Dudley Waite, City of Shirts.
And? You have a new title?
A really nice guy.
I'm a really nice guy. I'm a Cancer. I have 2 kids and 3 bulldogs. What else? I'm the chair of the GTAC EMS committee and our region's EMS committee as well. I think this is a tremendous idea, and I think running it through the EMTFs is critical, and it's all because of what you mentioned on the hospitals, because it's even worse for the pre-hospital guys when DSHS shows up, and we don't necessarily know that there's however many hundreds of divisions of DSHS there are. DSHS, they're all DPS to us, regardless of what their role is. And so running this through the MTF is huge. I also agree. I think we need to kind of flesh out what that concept would look like and maybe grow it to be strike teams, but I think we need to work with each EMTF region and potentially every RAC to determine who it is in that region that can handle this work. When this conversation was going on, a good friend of mine who happens to run the EMS system up in Spearman came up and mentioned in my ear that in Houston and Dallas and San Antonio, this is all well and good, but if one of these patients walk into Spearman or one of the other small critical access hospitals out in the frontier areas of our state, the issues become a lot more complex because the EMS employers are not necessarily employees. They're volunteers. They may or may not be covered by workers' comp. There's a whole myriad of issues that we need to identify ahead of time so that if that patient does come into Spearman, that the region has identified that there's an agency in Amarillo or there's an agency in Lubbock that can do that ground transportation. And like somebody said up here on the committee, that vehicle can be en route quicker rather than later because the hospital is going to want to get rid of that patient quicker rather than later. And there's going to be a lot of pressure on that local team to do it even if they're not prepared, especially, say, if the hospital owns that local team, which is the case in a lot of our outlying communities. So I think it's vital that we do that. I think it's a tremendous idea, but it's got to be driven through the mechanisms that we already have out there, the RACs and the EMTF.
From the audience, who thinks Dudley's on target with that? Raise your hand if you think that makes sense. But go ahead and raise your hand, okay? Anybody in the audience think it's not a good idea? Think we ought to start from scratch and build something separate? Bueller?
What's Joe think about it?
So we've had, so I reserved judgment. I wanted to hear from the rest of the group. Joe's in the back. We'll get to EMTF in a bit. But we have already, so what we did, I would say temporarily, kind of as an ad hoc response, is plan on our San Antonio Fire hazmat guys and some of the other agencies being able to do that kind of a capability when we were in the midst of this, right? Because it felt urgent. And so we put a plan together and had the commitment of the San Antonio Fire Chief and the Office of Medical Direction to be able to do those missions in our entire region. So we have already been walking down this path for a while. Some of the executive directors have met from some of the other areas, and I think there's support administratively, and the real question is, what does it look like? Flesh it out. Tell me what the concept is. How much is it going to cost? Is there going to be any help with those costs to buy extra equipment? There's another component that I think we're missing. I think we've talked about the PPE caches, because those frontline hospitals may have to do 12 hours or more, maybe longer, of care, of testing, of some things. And they, I mean, frankly, oh, well, they should have all that equipment there. It's like, well, yeah, they should. They should have a lot of stuff.
They don't.
So I agree. And it doesn't, and with the HPP cuts, I mean, we got a third. I mean, our region alone, one region was cut $700,000 in one fiscal year, in one swoop. You can't go buy a lot more PPE for rural hospitals when you're getting cut at $700,000 a whack. So I think that we need to have those caches that we've talked about before and be able to have them centrally where you could load them with that EMTF infectious disease response unit capability, and that rural hospital really gets some extra equipment, maybe some expertise, and then most importantly, the transport capability out of there. I think that will be welcomed. Rural hospital reps in the room, if you're listening, does that make sense to you guys? Anybody? Yes? I'm seeing heads nod. Anybody think that's not a good plan? I want to make sure I offer both sides. I'm not just trying to game it. Okay.
Okay, and so let me clarify one thing though, because we were talking about the transport teams, but are we also talking about a kind of like a nurse strike team, but not just nurses?
Sure.
So we're really talking two distinct teams, one for transport and one that we drop in services to a small hospital that doesn't have the expertise.
I think it's an a la carte. I think it's a cafeteria plan, and you guys would be in charge of deciding. I mean, I think it's like EMTF. You decide
Right.
if you want one MMU and 5 ambulance strike teams and 2 ambuses, and we have a conversation about what the need is. You say, we don't need any MMUs. We just need to go pick those people up and move them back and forth, right?
Right.
So I think having that capability and having some of the, so now we're back to the assessment center approach. If we have the buy-in from those assessment centers, who better to go do those things than the assessment center teams, as long as they know there's going to be a state mission assignment, they're being reimbursed for those responses like they would on an MMU. But if they go out there, they're the ones that are going to be taking care of the patient when they come back to the assessment center for 96 hours, right? Mm-hmm. So I think those are easy concepts for our hospitals to absorb. I'm not sure they're going to be thrilled, but they're going to be happier with that, where they have some measure of control over it and able to control those expenses and costs, where there's, if anything, the EMTF program has brought reliability to that reimbursement process. I will tell you that we've built confidence over the past 3 to 5 years in both the department and in the EMTF program, and I think that's where we have some, we ought to leverage that with those folks. Everybody, anybody disagree with that statement? It was sort of a long statement to agree with. Okay.
Okay. Well, thank you.
Really,
I appreciate the input.
Joe, can we sacrifice? We're going to go tight on your time, right? We have EMTF reporting out. I'd like to talk about. Can you put that same slide deck for the storms that you did yesterday at the end of the meeting? The 2, 3, 4 slide deck. Remember, I mean, it's not their website locations. I want the fresh ones. I want today's run. Okay. And that's all we'll do. We'll do that in 5 minutes report, because we're at 34 minutes, and we already covered Emily's agenda. I'm just making sure. I wanted to hear from the other two folks, or the other folk.
Okay.
Good.
Then I've got two things that I will do really quickly. One is I just wanted to share these dates with you, and there'll be more information coming out. We can also reinforce this, send out the dates through this committee as well as through the local public health, regional, RACs, others. So these are the meetings that we're talking about, the proposed dates of the meetings that we're talking about that'll be the regional meetings. And so these meetings, high consequence infectious disease response workshops, are intended to be for a wide audience. This isn't just healthcare and public health. It's local elected officials, the JPs, the judges. It's emergency management, absolutely. It's first responders, but not all first responders, not inviting in all the EMS and all the cops. But actually, if we could get those operational level people, the decision makers, to attend from the first responder community, then we're going to have, really it's a 3-day event, but it's a half day, full day, half day. First half day is general overview, lessons learned from Dallas, some general overview of kind of what the state of the response planning in that region. The next day is going to be a variety of different training tracks, so folks can just pick in different hours what track they want to go to. And then the third day, the half day, is going to be kind of a guided discussion / tabletop exercise where specifically for that region, we're going to walk through if we had we could call it whatever we want, MERS, Ebola. If we had a case in, say, Region 8, we had a case in Eagle Pass, we got to give them to San Antonio and take care of them. Walk through the scenario, who needs to be at the table. And so more to come on that, but I just want to throw these dates out there so people can kind of pencil them in, and more details will follow.
Kenneth?
Chief, I think that'd be a good topic for a TDM conference as well.
Yeah, I'm sending a message right now to make sure that all the DDCs and TDM staff are at all these meetings. But I agree with you.
Yeah, that'd be a good track.
Bruce, your hip ought to be vibrating any second now.
So
Thank you, sir.
So Bruce, so that's a perfect segue. I had a star next to an item. I've worked in disaster preparedness in this state for about 15 years, maybe a little bit longer. In general, I think that there has been a sense on the public health side of ESF8, when it's a hurricane, when it's a shooting, when it's a West, when it's it's like, hey guys, don't forget us. Hey, wait, remember there's a public health, right? There's always that, hey, you didn't call us on that. It's odd that you find yourself in this past 18 months where the reverse has happened, right? Suddenly, your agency is really the subject matter expert because it's an infectious disease. It's not a hurricane. It's not a law enforcement. It's not a riot. It's not, right? And so oddly, you would think that the public health people will be the most in touch with the sense that we need to be inclusive and we need to bring everybody to the table so that because they know what it feels like to be on the reverse side of that and be not intentionally discarded but forgotten. Right. And that's generally speaking, I think, where I've seen a swing and a miss, where emergency management, public safety has not been completely included in some of those things. I think it's an after action that we've heard over and over as a consistent thing. So if we can find ways to normalize that, and we should do it on the regular natural consequence things, we need to do it on infectious disease as well, that it's just the system is the system. Right, and we exercise the system. Everybody has confidence. I think Chief Kidd's done a great job in normalizing TDM over the last 5, 6, 8 years. It's amazing to see 6 years. It's amazing to see that people have confidence. They know their district coordinator. They know their state coordinator. They know that process, and we really need to rely on that because that's where people, in times of people get anxious about infectious disease. Mm-hmm. They scrub schools down. I mean, we need to build that information flow. Needs to be the same information flow. That's my recommendation. Same information flow, same conference process, same decision-making processes as best we possibly can. And that's another editorial, sorry.
And I agree. We've come a long way, and we still have a ways to go. I appreciate that. So more information will be coming shortly. A couple of quick points. We need your help to help identify, and Chief, thanks for sending that message out. We need your help to help identify people who need to come to this and promote it with us. We're also going to be reaching out through the RACs and others, trying to identify speakers for each region. We don't want this to be a dog and pony show. Like right now, they have me down for the first hour of the meeting to give kind of the overview. And frankly, I would rather have come down to San Antonio and have Dr. Kidd or somebody who's locally known, locally respected, part of the process there, get up and kick off the meeting. So we're looking to make these very customized, but also standardized. So we have some core content that everyone covers, but we get the names and faces of the key people who are going to be coordinating and responding to really drive a lot of the presentations. And so more to come on that. And then I know we're running behind. Real quick, 2 bills, and I've invited Jody here from Disease Control and Prevention. Just want to give you a quick update on this. I know this was a particularly distressing issue early on with knowing that we had people around the state that we were monitoring, and the first responders in a lot of communities wanted but did not have access to the information of where these people were. And so as a result, we've got this House bill, and I'll turn it over to Jody.
Hi, good morning. As Bruce mentioned, so we have 2 bills, and this one is dealing with information, making sure that all of our emergency responders are aware if we're monitoring someone that, well, they'll be given their address of where they are. So, they could get into a car wreck whenever they're not at home, and you wouldn't necessarily know that they're someone that we're monitoring. But it's a way that the legislature's made everyone who's EMS, firefighters, peace officers, anyone contained within emergency responders would be able to know if they're called to that house that they can be prepared and aware and know what sort of PPE or what sort of precautions they should take whenever they get there. This one, we are taking our time with the rules that we need to develop with this because there are a lot of concerns that we have. So how are we going to get this information out to these organizations? And then also the bill requires that the organizations remove this personally identifying information, the name and the address, as soon as the monitoring period expires. So making sure that that happens when there are how many emergency responder organizations across the state, and for everyone that we're monitoring, like Bruce was just showing, we've monitored over 1,100 people. So that aspect of it is very tricky, and we really need feedback, especially from, we've been brainstorming internally, but it's more important that you guys let us know because you're working on the ground, you're familiar with these systems, and I think you guys would have the best ideas on how we can ensure that that happens. And then also, again, the HIPAA and privacy concerns, because these are just people that are being monitored. They're not confirmed to have Ebola or any other disease that would fit into this criteria. We don't want the media to get concerned. A lot of eyes could see that these houses are where people are being monitored. So we need to just make sure and be very sensitive to that. So again, this...
So to make sure I'm clear.
Yeah.
2646 creates the environment for the department to release the location, and name or location?
It just says location of someone being monitored. It doesn't necessarily
address.
Specify. Yeah, and it says that
Okay.
we would release the minimum information necessary.
511 Main Street, there's someone in that house that has shown that's their home address.
Yes.
And that you're following.
Yes.
And that can be input into CAD so that when responders get that message on their MDT as they're responding to that location, to be prepared for the possibility that someone at that location is being monitored for Ebola or for a high consequence. Right. This is good for, by the way, this is good for TB. There's a bunch of, anyway.
That was a question is how, are all infectious diseases included in this?
No, so this is the other thing. It's the bill is very broad, so it says communicable diseases of concern, and then it also says being monitored.
Who makes that determination?
Yeah, so that's something that we're going to have to write into the rules. Now, TB is one thing that you are monitored, but you only are infectious for a short period of time. Once you've reached a certain part of your therapy, then you wouldn't be someone who could actually spread the disease to someone else if you're compliant and you're keeping up with DOT. So we need to really think through that as well. We don't want every disease to be out there, but anything that would fall into something like MERS or Ebola or something.
Are y'all involving infectious disease specialists, physicians, EMS medical directors, ER physicians?
Yeah, how's it, let me say it differently. How are you going to develop the rules, and could we offer some advice on that?
Well, we've had some internal brainstorming meetings with RLHS and regulatory, but instead of submitting this to the November council, we're going to wait until February because we really want to think through all of this and make sure we do it right and make sure we get a lot of feedback and input from everyone. So although the bill has it becomes law on September 1st, nothing will change until we actually write the rules and those are adopted, which if we submit them in February wouldn't be until the end of the summer of next year. So all the organizations that are involved in this won't need to do anything different in terms of getting information, removing information, that sort of thing.
We want to be deliberate, and we want you to be deliberate, there's no one anxious. I mean, we're anxious to do this. Public safety would like this to happen on September 1st. You may not want to do it on September 1st, but everybody wants the people who are going to the houses and not talking in little tubes, right? Those people who are going to the houses and knocking on doors and walking into those houses would like to know sooner rather than later. Dr. Kidd's point is very important. Do you know what CAD is?
No.
Okay. So there's a bunch of people who want to help you be successful. Computer-aided dispatch is what probably 95% of this state uses in public safety to type in, receive the call, and then comments can be attached to the address where that call is coming in. Mm-hmm. That computer-aided dispatch, that CAD system, I'm using words that you would say like, to you would be like LRN, like the most common initials in public safety, right? CAD, mm-hmm. Everybody knows. We have a bunch of people who are very interested in this, who understand the privacy issues and other things as well. The Medical Directors Committee, TDMS, I think is an opportunity, is a really good opportunity. We would like for EMS, fire, police, the communications personnel, the Office of Medical Directors at some of the systems to be involved in that. I know we can get you names. But you guys have to decide in the rulemaking brainstorming process to include those people from the front side instead of asking for public comment later and undoing and redoing a bunch of times. That will slow the process.
Right, and that's another consideration for why February would be the timeline. I understand the impetus to do this as quickly as possible, but in order to get all the feedback before we actually write the rules and it goes to public commentary, for example, for the November council meeting, we have to have our proposed rules written and submitted to our lawyers by Monday. So there's such a tight turnaround that we didn't want to push this too quickly. Because
what council?
I see this as a big privacy issue.
What council?
It's the...
What council?
Sorry, it's the State Health Services Council meeting. And then it would go to public commentary. I mean, it's a regular thing, a step that we only have February, June.
Rules go through there before they become rules after they're done at GTAC.
Is this a DSHS council or an
Yes.
HHSC?
Yes.
Right, Kevin, here, how does this work?
It's HHSC, who's our executive director, that approves the rules. So it's a very formal process that we have to introduce months before it actually goes into effect, and that's where that 30-day official comment period comes and all that.
Is there a DSHS council before there's an HHSC council?
Well, I believe HHSC doesn't get, I mean, it goes through our council. Our lawyers look at it, it goes to our council, it goes back to our lawyers. We have an opportunity to change
Is our
things.
council the DSHS
I believe so. This is I started in October during all these Ebola events, so this is the first council that I'll be involved in.
I'm simply saying we're filled with a room of really learned folk. This is, I'm going to tell you, I poked this, you don't even know, you kind of walked into a landmine because I sort of knew this was going to be a little bit of drama filled because for the last 8 or 10 years we've had rules that haven't moved forward. It's not clear since the commission, the old council, the original council that met in the 7th floor, right? There used to be, we knew where that was, you could go to that meeting, and it's been fuzzy ever since the other reorg, the 2008 reorg? 2004? Okay, in the 4 reorg, we went from 11 or 12 to 6. That changed that council, and it's been very difficult to get rules through. So I'm not sure anybody, I would love to know who knows, because I don't think it's clear. I mean, I know if I get a ticket, I have to go to municipal court and pay it. I know exactly how that works, but I don't think we know this other process as well as we probably could.
So the big difference is that whereas the Board of Health actually used to be the rule-making body.
Yep.
We have a DSHS council who approves things to move forward that now go to the HHSC executive commissioner, who is the rulemaking authority. So he proposes it, public comment, approves it, posted, it's approved.
Is he a council or just the dude?
Just the dude.
So the DSH, your lawyers will get it to the DSHS council, which basically is checking it out from a departmental perspective. And then it moves for one guy to evaluate, put out public comment for 30 days, and if no public comment that he wants to change or push it back down, then it's approved and it's law, or it's rule. Does that sound?
I believe there's also an opportunity after public commentary for us to change things. It's not like it would get kicked to the next rulemaking time frame. We would still hit, like if we were able to get something at the November council, it becomes law at the end of May. If we get something in February, it becomes law at the end of August. So that's the difference in waiting until
At the first meeting, if you had a flow chart, that would be really good to have, so people know just how long, when they're making changes now to the, trying to influence things and bring other stakeholders together, you're extending things by 12 and 18 months. If you can't visibly see that.
Sure.
Okay.
Well,
Chief,
just to,
do you have something? Go ahead. Yeah, I'll wait till that.
just to clarify, you said it's just the one guy. Obviously, he doesn't make things in a vacuum. The attorneys get involved and all those good things.
Right. But it's not a council. There's not another council after the other council.
Right.
Okay. So
They recommend, and he goes forward.
And my guess is that he's not reviewing it for content necessarily. I mean, he's not going to go, well, you said it was blue and I really want it to be red. I mean, it's just, have you
it's not a czar.
checked all the boxes that we've done all the,
departments are pushing things up. I would bet the hard part's getting through the council, the first step. Not hard, but the rigorous, right.
And Eric, I don't think it would be that big of an issue to develop a simple one-page flow chart to get out to you.
I think every
we
GTAC
can do that in
committee
a
would love
couple
to see
weeks,
that.
and then just make sure
It's
you
on the
have
website. It exists. It's right here. I'm looking at it right now.
Yeah,
And
there's
my
a-
recommendation is at the next meeting that take 15 minutes to go through the process.
Sure.
Wow.
I'll be happy
So-
to forward it to you.
So, in order to get this in front of the February council, am I saying that right?
Yes.
When do you need input from stakeholders?
I believe all of those. I believe it's in December that we would have to have all of our rules drafted and things like that. So.
Okay. This committee would love to help get you names. I know the TDMS process. Dr. Kidd is the program director for TDMS as well, the Texas Disaster Medical System. I think that would bring a broader group as well who might be able to help. Happy to get you names for that work group to provide the public, not the public health part, but the public safety, emergency management, EMS, fire, police side of that. I think we could help. Dudley, you raised your hand a second ago, like 10 minutes ago.
Yeah, I was just going to suggest that I'll talk to you offline, but I was just going to suggest taking it to the medical directors and GTAC. If she has till December,
Yep.
we can get the draft rule to those two committees before November. We can discuss it in November and then get you that feedback in time for you to make the changes to get it submitted in December. But the GTAC EMS and medical directors committee would be two strong places.
Is that this afternoon? ZMS and medical directors this afternoon? Tomorrow. Okay. We're here every quarter, 3 days, 3 glorious days.
I'd like
Group-
to.
Very strong group of people in this state. I mean, hundreds of people come to this meeting from EMS and emergency healthcare, trauma.
And next one's November, so there'll be even more EMS.
Yeah, they'll be in Dallas.
Okay.
Dr. Kidd?
Well, and I was going to say, we do TDMS monthly. I'd love to get you a.
Sure.
We have one tomorrow.
Yep. Voluntold. Okay,
If that's
anything
possible.
else? Anybody
Start
else
that
in the committee?
discussion. Sounds like we have a pretty short timeline.
Yeah,
One
we
more
have
bill.
we have one more bill. This one's this one's more straightforward. So SB 1574 is dealing with our emergency responders and the diseases that they can be tested for if they have a potential exposure. So this one opens it up. It adds this Code of Federal Regulations, Select Agents and Toxins. So this is something else that will add to the Texas Administrative Code and have conditions under which our emergency responders could be tested for them. Examples are like monkeypox, ricin, smallpox. Ebola is actually on this list as well, but Ebola is already part of that particular rule under the viral hemorrhagic fevers and the conditions under which you could be tested for that. So the legislature's just expanded how or for what and when you could be tested for these specific diseases. And then it also requires each emergency response entity to have a designated infection control officer and an alternate that could receive notice of exposure and follow up internally with their own people that there has been a potential exposure.
Dudley, you got this on your agenda, I'm sure.
We got the first draft to provide feedback on it, so yeah, we'll be a part of that.
This is a big deal.
Yeah, we've
This
sent out these
normalizes
draft
all the
rules.
Ryan White stuff. This is a huge deal for public safety with respect to being exposed to infectious disease.
And this is testing for source patient as well?
Yeah. Yes.
So, and honorable mention to Captain Bob Schlanger, by the way, from the San Antonio Fire Department, who's the infection control officer for the SAFD, and he wrote the vast majority of this legislation and have pushed it through. And the San Antonio Fire Association, lots of pressure from public safety in the state, really brought this to bear. And we owe them a debt of gratitude for getting every public safety first responder covered through 1574. It's a big deal. Lots of other people helped, obviously, but Bob Schlanger's a good guy, wrote this and did all the research to get the right laws to line up and stuff. And that was born out of a great deal of frustration with the old system where laws were all over the place to deal with first responders. Anything else?
No,
Any
that's it.
questions about that? All right, we got 15 minutes. JoJo? Thank you very much. That was really good presentation on the legislation.
Perhaps you can contact Bruce, because if you don't know me, I can give you my full name and my email address, but
Better if we get to Bruce, to you.
yeah.
Got it.
Just since you're familiar with him.
We understand.
then we can-
Thank you. Thanks, Bruce. Thanks, Carrie. Bink?
By the way, I'm going to take a minute while we're getting set up. Is TDMS meeting tomorrow is from noon to 3 at the DSHS SMOC. If anybody's interested in attending, it's an open meeting and certainly welcome everybody's input. So noon to 3 at the SMOC tomorrow.
Yep. Okay, so for the sake of time, we only have about 12 minutes left yet. So thank you, Danny Ramirez, for giving us the name for there you are. Tropical Storm Danny. Is this depression or storm? Storm Danny. Who in this room was in the response for Hurricane Ike? Raise your hand high if you're an Ike person. Okay? Who, you're in a position now where you'll be participating if there's a hurricane, but you were not involved in Hurricane Ike response. Raise your hand high. So we're at a 50-50 mix of experienced and people who have not been through a major hurricane strike in Texas. And it's an experience, I can tell you. This looks like, Nim and I disagree. Of course, he's got about 16 million scientists back behind him. I just have, me. That looks to me like the ugly Texas storm.
You've been reading the Farmer's Almanac.
The Farmer's Almanac there's a reason it's been around for 200 million years. Go ahead, Joe. What fuels tropical storms and hurricanes? Warm water, hot water. I know, I did this before. So there's the 89, 87, 90 degree water boiling in the Gulf right now. Then what steers major hurricanes? Giant pressure systems. So if, for instance, there was a giant high pressure system on the eastern seaboard and also one that was over the Baja Peninsula, then you would result in a steering mechanism to shoot the gap between those two with a vacuum sound from a low pulling it directly towards Texas.
What does the vacuum sound like?
It makes a sucking noise.
We got him to do it last night. I was just trying to do it again.
By the way, I got in trouble, speaking of vacuums, I got in trouble for a Mother's Day gift. I gave my wife a Roomba. Look at the shaking of the heads. It's an anti-vacuum.
How did that go?
It's an anti-vacuum. I don't want, never mind. But I'm telling you, it wasn't a weed eater. It's an anti-vac, never mind.
It was not a Lily camera.
Gadgets is not big on her list. Yeah. Get her a Lily.
Yeah. So what we have here is a Cat 2 storm on Monday, Tuesday, according to the National Hurricane Center, that I believe is the biggest threat that I've seen in the last 3 years. This is the first storm that's targeted. I'm not saying it's coming here. I'm saying that's what our storms look like. After 15 years in this business, that's what they look like when they come here. Now, I've seen them take a right after they get past Cuba and go straight into the eastern, tip of Florida. I mean, the western side of Florida. So I'm not saying it's coming here, but we need to be thinking this weekend, starting today, knocking off the dust. We have not done this in a grand way in a long time. The EMTF program is, I think, well poised and is in good shape, except for small fits and spurts and smaller jobs. It's not tested at a 3-alarm fire. We met with the AMBUS working group yesterday. I'm positive we can bring to bear 13 AMBUSes, and I think we can put 150 to 200 ambulances in a parking lot in less than 24 hours. EMTF folk in the room, who thinks we can do that? Raise your hand high. I agree. I think we can put 2 to 3 Type 1 MMUs together for a major response if we had to do that within 24 hours. And I think they could respond quickly. I'm going to tell you, I think that part's there. But the coordination and all the connectivity with respect to our evacuation processes, our interfacility transfer processes through RMOCs, all that stuff, we have a lot to remember and redo with muscle memory. And that's coming. Maybe it's not coming. Okay, be on your toes, stay frosty. I think this weekend there'll be a lot more information, and as soon as Monday, we could be in the H-120 curve making turns for preparedness. Do you agree with any of that, all that, some of that?
None of it. I don't think you should have got her a vacuum cleaner.
Anti-vacuum cleaner. All right. Any other? You have anything on EMTF specifically, Joe? You want to talk about?
We can do more in-depth stuff next time.
All right. We are in the process of redoing the MOA. That's going to be probably a year-long process, but we are taking into consideration some concerns that were raised by major healthcare systems. We've incorporated those. We appreciate those systems signing the first time, knowing that we were going to be doing a redo after a couple of years, and that work is being done in earnest. Well, for the good of the group, anybody have any comments or any thoughts on today?
You want to remind people about applications coming for open positions in this year?
For this committee? So, when do we start doing that? Is that already?
November, next meeting.
So, it seems like it was yesterday.
Next meeting is going to be in
Okay, so we are fast approaching, and you will see emails blasted out from the department about GTAC appointments to committees. We rotate off a third of the group every single year. So Michelle will send out something with who's coming up we'll know who's up and who's still okay. Members of the audience, if you're interested, and I'm saying this directly to you guys because you're the first ones I will consider. I'm not big on considering people to be on this committee if they have never shown their face. Frankly, I think there's a level of commitment people don't completely understand until they're coming. And if you're coming to there's some of you guys I've seen for 10 years at this meeting. Where was Robbie? That red carpet thing was hilarious. I mean, if you really remember the old days back at the old THA office off of 290, right just across the street actually, and they had this brilliant red carpet in their main conference room that if you ever walked in there, you will never forget that a room had a red carpet like that. And we met there for many years, for 2 years or more, and got a lot of good work done. Did we get those documents up? Were you able to get the ones I wanted to show real quick? Can you pull the Word document up real quick? We were doing them bi-weekly for a period of time after Rita, Katrina. Pull them up real quick. While they're pulling it up, I want to make a quick announcement and a congratulations to Chief Nim Kidd, who has graduated. What? He has now has his master's in public administration, and so we ought to congratulate him on that major step. We ready or no? Word document? Excellent. So here's a quick tour, a blast from the past. You guys remember this document if you've been here for a long time. This was the spring of '07. The work in '06. Scroll through here. This was our recommendations. Dr. Rock was the GTAC chair at the time, and Deborah Stabenow was an assistant commissioner, and Kathy Perkins as well. Rick Bays, was assistant commissioner. And those three people gave us our charge. Still had GDIM. Scroll on down. These were our recommendations. Stop. Okay, scroll.
Just said stop.
Stop. After the debacle of the Rita deployment, where people did not get paid for 13 or 14 months, the state could only sign up on their own less than 100 ambulances out of 3,000. Today, we could roster double that. Not how many we have signed up, rostering that. And that's because of the EMTF coordinators and the program folks. Go ahead. Whoa. We thought it was a good idea as a recommendation to add an ambulance strike team leader. Go ahead. Stop. The air medical helicopter, we thought that they incorporate flexibility to allow mission by mission and or extended duration deployment of air medical assets. 07 recommendation. We just got that through this year through the SCO now. We have the ability to do that, and we have all the major players in the state signed up for that capability right there. It's 2015. Go ahead. Whoa. That is an EMTF coordination center. If you really read through it about tracking assets and keeping up with things that are deployed, that has come to fruition through the EMTF program. Go ahead. Whoa. Ambulance and EMS personnel deployed for state missions in Texas using strike teams. We didn't do that before. Who'd have thunk it? In order to develop a statewide system, resources to be pre-packaged, one from one department, like Austin EMS sending the strike team, or one with multiple departments coming together and making an ad hoc strike team, which we do as a matter of course now, right? Go on. Whoa. The ALS bus, the paramedic bus. We thought it was a good idea to put paramedics on the evacuation buses. Not ambuses, mind you. We just wanted to do the ones we were using on the Coach USA buses. Go ahead. Whoa, ambulance strike team leader course. There are folks in this room that developed the ambulance strike team leader course in conjunction with TEACS, and we've deployed it, and now I bet there's 1,000 people that have been through that class. Air ground ambulance utilization criteria. Scroll down. Have to be on 4 liters or more of oxygen, continuous hemodynamic and cardiac monitoring, and have an IV drip that requires an IV pump to get an ambulance from a hospital. Otherwise, we're going to try to find other modes of transport for you. That was huge because we were wasting ambulances. Go ahead. Same thing for air medical criteria, still in play today. Go ahead. Altered standards of care in EMS operations. We now have EMTF medical directors and divisional medical directors on deployment that can help make a call if there's an ambulance that has a patient die and they still have 6 hours on the road. We have ways to do that are modified standards of care with direct communication with the medical director, and that system's in place. Regional medical operations centers. In 07, we thought it was a good idea. We're still working through trying to get these deployed in every state, every part of the state. Oh, thanks, man. EMS state deployment concept, keep going. Those were missed guys, by the way. Whoa. Medical care in the shelters. Medical strike team capability inside shelters. Keep going. Comfort station care. Keep going. The responsibility for the evacuating hospital to send their personnel along with those patients was critical, right? Keep going. I just highlighted some of the really important ones. Stop. Reciprocity concerns. Recommended bed definition concerns. These were things that were just not in place in 05-06. They weren't in place. Go ahead. Bed reporting processes. Go ahead. The fact we would pay by flat hour by type of aircraft instead of by mission, right? That chart looks familiar to the air medical guys. We just now solidified last 6 months ago. Go ahead. Whoa. Having doctors build this, EMS medical directors. Go ahead, scroll down. I think we're done. Anyway.
One question for the break.
Yep.
How many of you are still using radiological detection equipment on your ambulances or at your hospitals? Raise your hand if you're doing it. How many were doing it but aren't doing it anymore?
Better start.
Okay. That's all I have.
Well, you can't just say it like that.
I just did.
All right, we're
All
adjourned.
you have to do is plant the seed.
Michelle.
Thank you.
EMT's medical directors.
So this is your new.